So good afternoon everyone. I'm going to present a case of 73-year-old female resident of Delhi who came with the chief complaint of diminution of vision in left eye since 1 year. And the patient was apparently well 1 year back and she was apparently asymptomatic when she complained of sudden blurring of vision since 1 week when she presented in the OPD, which was insidious in onset and it was painless. Then there was no history of any redness, watering, photophobia, colored halos, glare, headache, brow ache, steroid use, night sweat, fever, sudden weight loss, cough, ocular surgery, trauma, or any other pigmented lesion anywhere else in the body. In past history, it was not significant. There was no history of any diabetes, hypertension, TB, asthma, any cardiovascular disease or renal disease or any other chronic illness. There was no history of any systemic illness. Then personal history, family history were non-significant. General physical examination and systemic examination of the patient were within normal limits. Then in local examination, visual acuity in right eye was 6/9, unaided, and in left eye it was perception of light with inaccurate projection of rays. Digital tension was normal in both eyes. IOP with non-contact tonometry was 15 in right eye and 16 in left eye. Extraocular movements were full and free in all the cardinal position of gaze in both the eyes. Lid and adnexa were normal in both the eyes. Conjunctiva was normal in right eye while there were prominent episcleral vessels seen near the nasal limbus in left eye. Right eye sclera was within normal limit, while the left eye sclera showed 2 into 2 mm region of scleral thinning, which was present near the caruncular region, as you can see in this figure. Then the cornea was clear in right eye, while there was fine endothelial dusting in the left eye. Then iris had normal color and pattern and no nevi in the right eye, while in the left eye hyperpigmented spots, that is iris nevi, was visible. In anterior segment in right eye, it was of normal depth when Herrick grading 3 with no reaction, while in left eye it was irregular in depth, ranging from Van Herrick grade 1 nasally to grade 3 in the center with no anterior chamber reaction. Pupils were normal in size and reaction in right eye, while the reaction in left eye was sluggish, both direct and consensual reflex. Then lens was clear in right eye, while it was nuclear sclerosis grade 2 in the left eye. Anterior vitreous was clear in right eye, while in left eye, anterior vitreous mass with neovessels and hemorrhage were visible on the surface of posterior capsule of the lens, touching the posterior capsule of lens. Then on fundus examination with distant direct ophthalmoscopy, glow was present in right eye in all the quadrants, while in left eye it was only present in the temporal quadrant. On direct ophthalmoscopy, disc was normal in size, shape, color and margin in the right eye. NRR was healthy, foveal reflex was present, while in left eye, the glow was present only in the temporal quadrant, media was hazy and rest details could not be assessed. On indirect ophthalmoscopy in right eye, background and blood vessels were within normal limit, while in the left eye, the media was hazy due to vitreous hemorrhage. Huge mass was seen in the vitreous cavity arising from nasal retina extending up till the anterior vitreous. Neovessels and hemorrhage touching the posterior capsule of the lens could be appreciated, and rest details were not clear. Then this is the picture of right eye, which was normal. This is the dilated pupil image of right eye, and similarly the left eye. Here you can see that there is visible neovascularization on the posterior surface of the lens, and there is nuclear sclerosis grade 2. On USG-B scan, there was no proper A scan overlay for this patient. Evidence of large echogenic intraluminal polypoidal soft tissue lesion of size 18.6 into 13 mm was seen in the vitreous chamber of the left eye with internal vascularity. However, no obvious extension was seen into the surrounding soft tissue along the optic nerve, and the surrounding orbital fat appeared normal. Then this is the MRI brain and orbit with contrast. Here you can see a well-defined, mildly enhancing T1 and T2 hypointense polypoidal lesion of size 13 into 14 into 15 mm, which was seen in posterior chamber of left eye. Anteromedially, the lesion was extending up to the lens, abutting the posteromedial margin and its medial attachment, causing the anterior bulge of medial ciliary muscle. Then also vitreous hemorrhage was appreciated with maximum thickness of 7.7 mm, and right ocular globe was normal. Then whole body PET scan was carried out for this patient, where FDG, avid enhancing polypoidal soft tissue density lesion of size 1.6 into 1.4 centimeter with maximum volume of 22 FP641 was seen in the posterior chamber of left eye, and no cervical lymph nodes were appreciated. Then investigations were carried out for this patient, and in view of scleral involvement, enucleation was carried out under local anesthesia, and sample was sent for histopathology. This is the image of the sample, the enucleated eye, and this is post-op 1 day image with confirmer, and this is a post 1 month image with prosthetic eye implantation. Then on histopathology, tumor size was 1.8 centimeter. Tumor growth was, it was a solid mass. On histological type was 90%, greater than 90% were epithelial cells. So this is grade 3 uveal melanoma. Scleral involvement was present, and ocular structures involved were choroid and vitreous. Tumor location was between the choroid and ciliary body, and the TNM staging was P, T3, NX, MX. In view of scleral involvement and ciliary body involvement, and impression was left eye malignant melanoma. So the case summary is 73-year-old female presented with complaint of gradual onset painless and progressive diminution of vision left eye for past 1 year, and then visual acuity was 6/9 in right eye, and at left eye it was PL positive, PR inaccurate. Enucleation was carried out for this patient, and histopathological examination revealed the lesion to be malignant melanoma. These are the differential diagnoses for my case: malignant melanoma, choroidal hemangioma, choroidal mets, and choroidal nevus. Thank you.
Was there any nevi in the right eye?
No, ma'am. There were no nevi, no hyperpigmented spots in the iris.
Show the picture, clinical picture.
हाँ जी मैम.
The first view, right
Okay.
eye. Right eye. I thought there is
Inferiorly.
inferiorly. This one. Is that a nevus or
No,
just a
ma'am.
shadow?
It's just the shadow, ma'am.
Why the shadow will be so localized as if it's only confined to the iris? Can you explain?
Ma'am,
Yeah.
it's just the shadow.
Okay, how was the IOP in that affected?
Ma'am, IOP was absolutely normal. It was 16 by NCT, and digital tension was also fine.
So, is the neovascularization seen as a part of your?
Yes,
is there a
ma'am.
chance of patient developing a neovascular glaucoma, or you want to?
Ma'am, there was neovascularization on the surface of the tumor, and since it was touching on the surface posterior capsule of the lens, so neovascularization was visible on the posterior
Okay,
surface.
when you did the B scan, you saw a large mass, right? What is that one investigations you want to do before going to PET scan? That you want to rule out the mets in which organ and which blood investigation you want to do?
Ma'am, ultrasound whole abdomen can be done.
What is the most common site to
Liver.
get mets?
Liver, ma'am.
So you should do liver function and liver.
Yes, ma'am. MRI of liver and